So all the drilling, cutting bones, correction, putting the plate, and all the correction is used using this 3D printed jig, so that the corrections are perfect degree to degree. Okay, so if this is a case of genu valgum, you can see the child is standing with knock knees are touching and ankles are far apart, and this child has already finished growth spurt. So if the child is still growing, has 2 years of growth left, then Dr. Avi will tell you in the next talk how we will correct this deformity. But if the child has finished the growth spurt, the girl has got periods, the boy has already developing secondary sexual characters and skeletal maturity is achieved, the only way we can correct deformity is by cutting the bone. And the way we used to plan this earlier was a paper planning. So we used to take an X-ray and take X-ray sheets and, in some way plan the wedge that this is what we'll do to correct the deformity. And some of the inadequacies of this method are that this is a 2D planning. Secondly, you plan, but you cannot execute to perfection. And that's why we do this 3D planning. We don't only have X-rays, this also requires CT scan. So 3D data comes from a CT scan. And we do a process called segmentation to convert a CT scan. CT scan is basically sections. The series of sections are converted into a 3D model of the bone. And we do a virtual planning on the bone. So all cutting on the bones, correcting, putting the plate, everything is planned on the bone. Based on this, we design a guide. This is also done on the computer. We print this guide with help of a 3D printer. So we get whatever we design, we get it in hand as a final product. And finally, that is used during the surgery to correct the deformity. So we'll see this small video of a 14-year-old female with bilateral genu valgum. Right. So this is genu valgum. You can see X-rays and scanogram. The first step is to do a CT scan. And from the CT data, we do segmentation. You can see this segmentation being done. And at end of segmentation, we actually have a 3D model of these bones with us. This we superimpose on scanograms, and then we get a 3D model in a standing manner. And on this standing model, we calculate the angles. And after calculating the angles, we decide what deformity, how much is to be corrected. And this planning is done on computer. This is all being done on computer. And then we plan different translations. We decide how the plate will sit, how the screws will go. And based on the direction of the screws, we go back to the deformity and plan when we start operating, how do we pass these screws and cut the bone so that we get deformity correct. So on table, when we take an incision, put the surgical guide, you can see that we can put all drilling through the surgical guide. So it's computer generated, doesn't involve any human skills. We do cutting of the bones through this guide. This is a wedge which is removed. You correct the deformity, and the pre-bent plate, once you part screws through the plate, the deformity gets corrected. So it's as simple as that. It reduces the operative time, reduces the blood loss, and most important, it gives you complete correction as it was planned. So this is the patient 1 month post-op. You can see 3 months post-op. The other side was done after this. And after completion of the other side surgery, she's completely straight and she's able to walk and do all the work she has to do. So this is how a 3D planning is done. And this technology works. And we've used it for now number of cases in upper limb and lower limb. For example, in upper limb, we use for humerus osteotomy, you have cubitus varus following a supracondylar fracture. You can correct it using this technology. Malan united fractures, you can correct using this technology. In lower limb, hip issue can be corrected, general can be corrected, deformities of knee and ankle can be corrected, foot deformities can be corrected using this technology. So we'll show you some of the cases where actually it has been done. So this is a case of Coxavara where the neck of the femur is bent down, and these children typically walk with a waddling gait. And what we do is do a CT scan and then do a paper planning first. And this is how we do a 3-dimensional planning. prepare a surgical jig. You can see the surgical jig in the turquoise blue color, which has been planned. And then different plannings, different types of plates we can decide. So there is no jugglery on table. On table, we are not struggling. Whatever options we want to try, we try it on the computer. And then this is a surgical guide which is decided, printed. And then during the surgery, we simply place this guide after exposing the patient's bone, make cuts, do drill holes, and put the plate. And you can see this deformity is completely corrected. This child's neck shaft angle is corrected. The trochanter has been brought down, so that will enable this child to walk normally, and that will result in a long-lasting hip and a normal walking pattern. So you can see the planning and execution. You can do absolute perfect execution of what is planned with this technique. Uh, so this is the patient post-operatively doing well. This is a patient again where a planning was done for a very complex case. This child had fracture neck femur, which was treated with screws, but because of the screws, he ended up having shortening of the leg and shortening of the neck. And he had a bad limb. He could not run, he used to fall often. This patient is from Tanzania. And then we had to plan this surgery where we would elongate the neck. This is a neck elongating surgery. This will also result in limb lengthening and improvisation of the gait. So very complex surgery, we were able to plan this on a computer model. So this is how it was planned by shifting the bones and elongating the neck. We also planned which implant to be put, how do we put this implant, and then planned a surgical guide to execute this surgery. So during surgery, we expose, put the surgical guide, make the cuts, put our implants, and then you can see planning on the left side, execution on the right side. We could have this child to walk absolutely fine, joining back to sports and football, which he wants to do in Nairobi, and doing really well. You can see actually he is walking with walker lifted off the ground, and his limb has been completely corrected after this surgery. So this is possible thanks to 3D planning and help what we get using these 3D jigs, and this is completely indigenous, homegrown technology made in India. And this is something for which now patients come to us from other countries, and doctors from other countries are also using this technology. So another case, just to give examples, a forearm malunion. In children, fractures heal, they remodel, but they have to be aligned well in plaster. If it's not aligned well in plaster, sometimes they undergo malunion, and this is a complex malunion where in both radius and ulna there is a rotational problem and angular problem, and this resulted in the child not being able to do pronation and supination. So in the image on the left, you can see he's not able to supinate fully, and that prevents him from eating properly. He's a right hand dominant person. He's a badminton player. He cannot play shots, and because that requires full supination. So this is an X-ray, and from X-ray it's very difficult to plan because this is a two-dimensional depiction of a three-dimensional deformity. And what we do here, going by the experience of work of people abroad, we did a 3D planning and small video to show that. So this is actual deformity of the bone in a 3D manner, and this is how we want to correct it. Okay, so this is the plan, surgical plan, where we do a radius osteotomy and decide how do we put the jig so that when the pins are aligned to each other, the deformity will be completely corrected. The angulation, the rotation, the translation, everything, how it is going to be corrected, we plan on a computerized 3D model. So this is how it has been done. And once this is done, we prepare a surgical guide to actually execute it during surgery. So there are two surgical guides which are prepared, one pre-op and one post-op. And this is, you can also practice the surgery on bones. So we printed the bones, practiced the surgery on a 3D printed bones so that we were sure that everything would be fine. And this is during surgery, exposing the bones, cutting the bones, everything done using a computerized surgical guide, and then putting plates and putting screws through pre-drilled holes, cutting the bone from with the osteotomy which were decided by the computer. You can see that this is post-op X-ray, and this child had regained his complete range of movement, can see on this video that he's able to do pronation and supinate completely, and he's able to do all activities. So it's a big boon to the child. So this is a child from Surat who had a malunited distal radial fracture, and then she had a lot of issues because you can see whole radius is tilted dorsally, and functionally you can see again here there is restriction of wrist movement and inability to do supination. And in spite of therapy, exercises, and waiting, nothing helped this child. And you can see on CT scan how much is the deformity, and this requires exact correction because it's not only angulation, it is also loss of height of radius. And when we do a 3D planning, we realize that what you see in pink here is what is loss of height of the radius, which also needs to be built for, accommodated, and taken care of. So then we planned 3D planning for this patient, uh, and I'll show you. This is a plate which we planned, how the screws are going to go. And this patient, we took incisions and put the surgical guide on the bones, did drilling, osteotomy all through the surgical guide, and then put the plate. You can see plate is off the bone. As soon as the plate is put on the bone, this deformity gets completely corrected, and the level of radius and ulna now match, the angulations match. This has become to a pre-injury status. We could correct it to a normal anatomy. And because of that correction, you can see immediately the range of movements improve on table. And this is post-op. You can see she's able to do all activities. She is a commercial artist, and she's very happy. She's a left-hand dominant person, that she's able to paint and draw and do computer graphics after this surgery. So a few more cases we've done, cubitus varus being corrected through a percutaneous technique without any incision using this method. And now we have experience of almost 100 cases with this method. So take home message for everybody is that this is a new technology made in India, available at SRCC, where children with deformities can be 100% accurately corrected, using this technology. And as all of you know, at SRCC, and any child where cost is a constraint to get the best quality or a state of the art treatment, they are helped through our trust. So, even if parents feel that they are not able to afford such high technology, at SRCC it will be possible to treat them by a very generous help from the hospital and the trust. So with this, Avi, I want to end my short presentation. I hope there is a new technique, and I've been able to convey it in a very simple terms to everyone. Thank you.
Thank you, sir, always for your amazing talk and showing the use of this new technology for everyone to be aware of, so that people get an idea of these kind of things. As such, there are no questions from the house. So then I'll move ahead with my talk. And if at all at any point anyone has questions, please feel free to put it in the chat box so I can ask whomever you want for these kind of things.
Sure.
Thank you, sir, once again.
All right. Thanks.
So I'll just share my
Do
screen.
people have any questions? They can just either raise their hands if the people are actually attending, then, or put them in the chat box.
Yes, please.
Or let's give them a minute if somebody
Yes.
really.
Yes.
Okay. I don't see any questions. Avi, you can go ahead.
All right. Thank you so much, sir. So I would just like to apologize for the background sound. I'm traveling. So I'm going to be talking about technology which is much simpler than what sir showed us, but it has great power, and it relies a lot of understanding on nature and how children grow. So I'm going to be talking about growth modulation and how we use the power of growth to guide deformity correction. So thank you for all this opportunity, and I'd like to thank all of my colleagues with the amount of great work that we are doing at SRCC. So we know that children grow. They grow from babies to infants to teenagers. They change as they grow. It's an amazing process. And this process is the mainstay and it defines our specialty, that is pediatric orthopedics. And that is what captivates most of us, and even me, and has guided my career till now. And we see many deformities, as even Dr. Taral has shown, along the way in this process. And this is one of the techniques that we can use to correct these deformities in a much minimal invasive and small way. So as we see children across various age, we will see different presentations like genu varum, valgum, and at different age groups. And some might be physiological and some might be pathological. Pathological can be secondary to rickets, Blount's disease, skeletal dysplasias, trauma, infection, tumors, so on forth. So we need to first understand how do we really need to differentiate between the physiologic and pathologic varieties so that we know what is the right way to manage these and guide these patients. So the normal development of the lower limb, most children are born with 10 to 15 degrees of varus, that is bow legs to certain extent. It neutralizes by around 18 to 14 months, then goes into knock knees by 2 to 4 months, which is the maximum age, the degree of knock knees. And then again by 4 to 7, start neutralizing to the adult position of mild valgus. So that is how every child and every lower limb alignment progresses. So we need to understand at what phase does this child come to us? Does it fit into the physiological zone or it relates to the pathologic zone? So again, we also need to know the phases of growth. So there is, in the prenatal age, there is an exponential growth of the child. From birth to 5 years, there is a fast, rapid growth. From 5 years to puberty, usually there is a stable growth. And then after that, again, we get the secondary growth spurt. So in the secondary growth spurt, in the puberty phase, you have an acceleration phase, then you reach the peak height velocity, and then after 13 years in girls and about 15 years in males, you have a deceleration phase, which grows right up to maturity. So in majority of the angular deformities, they tend to present in this age group, that is from 10 to 15 years in majority of our patients. And this is where sometimes the dilemma comes of, do we offer growth modulation or osteotomy like Dr. Taral showed in his previous cases? Because for growth modulation, we require growth to be present. At least 1 to 2 years of growth remaining should be present. So when we see these children, we need to understand their clinical features, the age at onset of the angular deformity, how fast the deformity is progressing, and also need to understand their family history, if it is familial, especially conditions like skeletal dysplasia, metabolic conditions other than rickets, nutritional habits, significant past history of either trauma or things like that that can lead to deformity. And we also need to know the natural curve. As I have shown before, the natural curve of the normal limb alignment, if we know this, based on the age group, we will know that does it fit into a physiologic age or a pathologic range. Again, we need to see the symptoms of these children. So the most common symptom is the appearance. Most parents come to us because of the appearance of the child. Either it is bow-legged or knock knees. They come with gait abnormalities. They have repeated falls, sometimes difficulty in running. Their walking pattern can be slow. And they often have knee pain or discomfort. So here you can see different child. This is a 3-year-old child with genu varum. You can see here, this is a 5-year-old child. How he walks, he has significant genu valgum. You can see the thrust and how his knee goes when he walks. This is a 10-year-old female with genu valgum. So you can see her legs brush every time she walks. And this is an older child with a deformity. So you can see how this girl with genu varum walks with keeping her legs apart. So we get these kind of deformities at various ages in various presentations. So again, in clinical features, look out for short stature because most metabolic and skeletal dysplasia children will have short stature. Obesity usually has a correlation with Blount's disease. We look for ligamentous laxity. And in general appearance, do not miss out for certain signs like widening of the wrist, at the ankle, and the chest for signs of rickets, which is very, very common even in urban population. Now, the other assessment comes of, is it a unilateral deformity or is it a bilateral deformity? A unilateral deformity goes more in favors of certain conditions, like example, Blount's disease. And most other conditions which are systemic are usually bilateral. Again, symmetrical and asymmetrical. Symmetrical meaning they are exactly same on both sides, and asymmetrical. So we can have various presentations in even metabolic and other conditions. So we need to know the assessment of this deformity before we go ahead with correction. Again, the clinical features, the basic sign that we see is the intercondylar distance, the intermalleolar distance, the tibiofemoral angle. These are the most common examination points you can do in clinic to know is this a physiological condition or a pathological condition. Again, there is another test known as the flexion test. This tells us which bone is deformed. Is it the femur or the tibia? So when you flex the knee and if the leg appears straight, the deformity is from the femur. The other test is known as cover test. So in the cover test, like you can see in this child, there is bowing of the legs. So you take a paper or anything and cover the lower half of the leg. So if the upper half, you can see it is straight and in slight valgus position, that means that is normal and there is a distal tibial bowing. And that usually, this is quite often seen in children who have been treated with rickets, as the tibial bowing and the lower leg deformity takes a long time to correct. We need to be very, very careful about torsional deformities because these can be a trap and can give you a picture of a different thing. So like here you see this child, he's a child of hypophosphatemic rickets who has an O deformity. But as soon as you flex the knee, you can see the tibia is still bowed and the foot are completely turned inside. So this child, even though has an angular deformity, has a quite significant internal torsion. And that leads to him walking with an in-toe gait as well. We also need to check the clinical profile by assessing the torsion at the hip and the tibia to be careful before we plan treating these deformities. And there are special investigations that we get. One is the hand and wrist x-rays to know the bone age. We get full length mechanical axis views, which help us assess the complexity and the variation, the degree of the deformity. At times, we may require MRI scans in certain selected conditions. And then we do biochemical markers, your calcium, phosphorus, alkaline phosphatase, vitamin D, at times parathormone, urine calcium, urea, creatinine, and the basic renal profile. So let's see now these two patients. There are two patients, both 11 years old. Apparent they should be the same, but even at the same age, they are not the same. One at the same age is premenarchal and one is postmenarchal. And if you look at the X-rays, one's physis is open and the second one's physis is closed. And this again changes the way we would treat these children. So as we move ahead, we need to see that the chronological age as such for us is not very, very significant. We need to look at the bone age for most of these children to plan corrections with these type of methods. So the bone age is a much better predictor to plan these kind of treatments. So to assess our bone age, we have various x-rays of the elbow, the foot, and then looking at all of these charts, we can give a prediction of how much growth is remaining in these children and if they are applicable for these type of newer techniques. So this is a child, a 13-year-old child with genuvalgum, you can see, who ended up needing an osteotomy because the physis is closed. This is a young child with a very severe deformity, has needed an osteotomy, but could have been even possibly corrected with growth modulation. So with bigger surgeries, again, there is a major risk. These are major surgeries. There's a risk of blood loss. Sometimes they require plasters, long rehabilitation, prolonged stay in the hospital. There can be loss of school days. So if at all there is a possibility of treating them with growth modulation, it is a much better option. These are minimal invasive, at times daycare surgeries, no plasters. The child goes home walking and can get back to all their activities within a week's time. So the utility of this has been shown over the years and has been most significantly shown to us by Peter Stevens. So basically, what is growth modulation? So we use a plate, which is known as an 8 plate, as shown as the image over here. So it acts as a tension band principle and temporarily stops the growth at the growth plate on the side we attach it. So once we put this, it temporarily stops the growth on one side, allowing the opposite side of the growth plate to grow and internally correcting the deformity as the child grows. But we need to make sure there is at least 2 years of growth remaining. So basically, we can use this in most age groups, each sizes, most of the etiologies, directions, and locations. but we preferably do not use them when the physis means the physis is sick. That means either there is a bar or there is a condition in which we cannot predictably see growth from the physis. And this is a minimal invasive condition, short hospital stay, and the child walks from day one. So I won't go into the surgical technique, but I will go through some cases. So this was a 7-year-old child treated with rickets, still has a significant deformity. You can see the intermalleolar distance is 21 centimeters. He underwent growth modulation, and see within 11 months, his leg is completely corrected. During this time, he could attend school and do all his activities. Similarly, this 4-year-old child with Blount's disease type 1 underwent growth modulation, and within 13 months his leg is completely corrected with this minimal invasive technique. This is a 2-year-old child with skeletal dysplasia with severe bowing, and she underwent growth modulation at multiple levels. And then you can see her axis at 2 years is significantly deviated. The at 3 years, you can see after growth modulation, her limb is completely corrected. And then that is at her at 4 years with a straight limb and still undergoing treatment because of a skeletal dysplasia. So this is a 3-year-old child who had a proximal tibial fracture, which was treated with a cast. But you can see he had a genuvalgum deformity. This is known as Cosen's phenomena, and this should be looked at. So this child, we waited after his fracture was treated elsewhere. He came to me at 1 year after his fracture and with a significant deformity. So he underwent growth modulation. And then you can see within 9 months, his leg is completely straightened out. This is a 6-year-old child, a known case of hemihypertrophy and genuvalgum. So she has leg length discrepancy plus genuvalgum. So with this minimal invasive technique, we have not only corrected her genuvalgum, but also leveled her leg length discrepancy as well. So with this technique, the children may require multiple small procedures, but with minimal invasive techniques, in 6 months, her genuvalgum was corrected. And then after that, we changed the plates to correct her leg length discrepancy. And at long-term follow-up, you can see now she is completely leveled at her leg length discrepancy. The other way of we do this technique is a surgery known as PET screw, which we use for older children above 10 years old. The principle is very similar to the 8 plate. So this is a 12-year-old female post-menarche. We see her elbow X-ray. The olecranon apophysis is open. That means she still has growth remaining. Her intermalleolar distance is 25 centimeters, as you can see. So she underwent this surgery with the screw, a percutaneous screw with a very minimal scar. Within 8 months, you can see her leg is completely straightened, and then the screws have been recently removed. This is a 13-year-old male, a known case of multiple pituitary hormone deficiency who was under treatment at SRCC by our endocrinology team. And you can see he has a significant deformity. This is him walking. You can see he walks with significant genuvalgum and his knees rub every time he walks. So again, he has growth remaining. So he underwent this percutaneous technique of growth modulation. And then you can see within 9 months, his legs have completely straightened. He is under treatment with endocrine, and we are constantly monitoring him because he is at a high risk of his deformity recurring because of his hormone deficiency. We have other applications as well, not only for limb. I have used this growth modulation technique even for children with knee flexion deformities to correct their flexion deformity. So this child of cerebral palsy underwent this growth modulation technique, and then you can see him. He had a correction of 1 degree a month, and within 10 months' time, his legs are completely straightened out with this very percutaneous minimal invasive surgery. We have not had to cut his bone or do any significant type of surgery. And now he's under rehab and is able to walk and do well. You can see him here, even walking with support, and is undergoing rigorous therapy. We have also used it for deformities around the ankle. So this child of spina bifida had an ankle valgus, and I used this technique to correct her ankle deformity. Though these kind of deformities may take a longer time, but these are much smaller procedures where we can use this technique. We have also been using this technique for the hips as well now. I have done 4 to 5 cases. Though we have limited follow-up of these cases, we have recently starting them. I have had a couple of good results where children with cerebral palsy, where their hips are subluxing, with this minimal invasive surgery, we put the screws in. And in the long term, we have seen that this helps us maintain the hip from subluxing and dislocating out. There are newer reported applications as well. I have not used it in these other techniques, but we are looking into seeing them if we get the right candidates for treating genu valgum, for treating distal radius, even for treating scoliosis. Our surgeons have been using them for treating hallux valgus and other tibial bowing deformities. These growth modulation techniques have also been used. So in summary, this is a very new technique and it's a very simple percutaneous procedure, but the children need to be referred at the right time. Do not sit on these deformities that wait for these deformities to correct with maturity, because then they will end up needing osteotomies. So if they come to us in a younger age where growth is possible, we can treat them with these simple minimal invasive techniques, and they can get very good deformity correction. So one, you need to understand these the conditions. Are they physiologic or are they pathologic? Be familiar with the normal development process of these kind of conditions. Do not wait and sit on these deformities until maturity. There are no more roles of braces. Like previously, people have been advised bracing for correction of these deformities or plasters. As such, with newer literature, there is no role for bracing and plasters. This is a very simple procedure. The child is back home the next day, back to school within a week, walks on the same day. The movement comes back within a couple of days, and the family and the child is very happy, and it uses the power of growth for their deformity to correct. Thank you so much for this opportunity, and sorry about the noise in the background. So if you have any, and these kind of conditions are very regularly seen in your clinic, please do refer them at the right time so that we can help these children with these kind of newer techniques to correct them at the right time. Thank you so much. So I will stop sharing my screen. If there are any questions, please feel free to ask or put it in the chat box. And till then, I would like to invite the next speaker, Dr. Mandar Agashe, and he is going to be speaking to you regarding what to do and not to do in pediatric osteoarticular infections.
Thank you, Avi.
Yes.
Am I audible and is my screen visible?
Yes, you're audible and visible. And
Yeah.
since there are no questions, I think you can go ahead.
Yeah. So I'll be talking to you about something which is very commonly seen, which is pediatric bone and joint infections. And what is unique about pediatric bone and joint infections is that there is a wide variety of clinical features, because the child is not going to tell us where the symptoms are. They're often vague and non-specific. And with the advent of newer and newer microorganisms, the complexity has increased over the years, and each case is unique and is an opportunity to learn. There's a very famous orthopedic surgeon named Scott Cousin, who in his very good article in 2004 had said, antibiotics save the life and surgery saves the bone. A small couple of examples about regarding the same. This is a 3-year-old female who was hospitalized within the first 48 hours of symptoms. MRI was done immediately and drained within the next 6 hours and followed by appropriate antibiotics. And this is her after 1 year showing excellent range of motion with no sequelae. As against that, this is another child who presented after about 18 days of developing symptoms, initially treated only with antibiotics, and surgery was done on the 19th day and finally came to us after a long time with a significant deformity with discharging sinus and stiffness. Thus, what is important to note is that surgery at appropriate time saves the bone. So this is going to be the crux of my talk this afternoon. Because what we know is that septic arthritis and osteomyelitis is one of the true surgical emergencies in pediatric orthopedics. It is usually a result of hematogenous seeding of the synovium with increased intraosseous pressure, vascular thrombosis, with spreading of the abscess to the subperiosteal bone, which devitalizes the cortex. Now, typically, the child has these symptoms. There's severe pain, there's severe swelling, tenderness over the affected fever, Now, pseudoparalysis is basically a pain is timely diagnosis, prompt decompression, and effective antibiotics. I'm going to illustrate a few cases to which show how to exactly manage and what not to do in these cases. So this was a 5-year-old male child with history of fever since 2 days and swelling in the forearm since 1 day. The X-ray was reported as normal and the ultrasound was done which showed forearm abscess. The general surgeon then did an IND and you can see that initially there was nothing on the X-ray, but slowly the changes of osteomyelitis came into view. You can see that there is significant changes in almost the entire ulna. And slowly this entire ulna had got sequestered and eventually surgically a large portion of the ulna had to be removed. Thus, what is important to note is that we should never think that any infection which is deep to the deep fascia is just an abscess. Usually and almost always it has a possible bone and joint infection and hence it has to be treated as such. Another case where you can see that this was a 2-month-old female child, history of acute onset decreased movement of right lower limb. If you can see that the left limb is kicking and the right limb she's keeping it flexed. So this shows that this is known as pseudo paralysis and this is very important to diagnose this early. What you should stop yourself from saying, kuch to infection lag raha hai, let's start antibiotics. Well, you should never do that. What should be done is that we should think that this can be septic arthritis or osteomyelitis. We should admit the child, run a few tests, and only after doing those tests should we start antibiotics. And what are those tests? We should do CBCSR, CRP. Important is to do a blood culture before starting antibiotics. So you should give the first dose of antibiotics only after the blood has been sent for culture. You should never start antibiotic before doing a blood culture or preferably a drainage and a pus culture. What is the imaging we should order? You can see that the X-rays typically are reported as normal, but many a times you can see these soft tissue shadows around the joint and the bone, which shows that there is something wrong which is going on here. However, there are specific changes for septic arthritis and osteomyelitis which may not be apparent for the first 10 to 15 days. Ultrasound is fairly useful, though it can just show the presence or absence of septic arthritis, but it is highly operator dependent and does not show concomitant osteomyelitis. So, is this information enough? Well, most of the times an MRI is required. MRI will show not only the joint effusion, which can be seen in ultrasound, but also will show the involvement of the bone, which is concomitant osteomyelitis, which should never be missed. Hence, MRI is the gold standard imaging modality for septic arthritis and osteomyelitis. And hence, always remember, this is how you should write. MRI plane and contrast of the hip with screening of the psoas, pelvis and the proximal femur, because that is where concomitant infection can be there and hence it should never be missed. Treatment is in form of medical and surgical treatment. So this article is going to just come in a few days. I was one of the co-authors, which is a consensus management statement of bone and joint infections from IAP. So the duration, choice and dosage of antibiotics has been given. What is important to note is that for all routine organisms, IV antibiotics can be given only for about 5 days, after which, after normalization of clinical parameters of fever and CRP, you can shift over to oral, which need to be continued for about 6 weeks. This is what has been given. The two common organisms are the MSSA and MRSA, for which cefazolin or cloxacillin is to be used for MSSA, and vancomycin is the first short choice for MRSA organisms. There is some role of steroids in septic arthritis, especially when you can give a short dose of steroids in order to treat the symptoms of synovitis, fever, and pain. Surgery is the mainstay of management. This involves either aspiration or open arthrotomy. Aspiration can be used in useful cases only in superficial joints like knee, ankle, and the elbow. It can be useful for obtaining fluid for culture, but should not be used in isolation, as it does not irrigate the joint well, and sometimes in thick effusions, this may not be useful. The main treatment is an arthrotomy, which is the surgical gold standard for septic arthritis. because negative arthrotomy is better than missing the bus, because it should not be that the cartilage should get damaged, and it should be done as early as possible. This is the common area for doing an arthrotomy, which is the anterior approach. While in osteomyelitis, what is important to note is that you should remove the subperiosteal collection once it forms, where the decompression of the metaphyseal bone is the hallmark of the treatment. This is how it should be done. The metaphyseal bone is the epicenter. This is where you should approach by doing a cortical window. But you should remember that the physis is very much close. So you should beware of injuring the physis, and see to it that you immobilize the limb for at least 4 to 6 weeks. Always remember that sometimes a tumor can mimic an infection. Hence, always send the samples for histopathology along with cultures, and all sorts of cultures should be sent, including TB culture, because sometimes in kids, TB can present in an acute manner, just like a pyogenic infection, and hence this should always be investigated. So this is how you can get a good follow-up after 1 year. At the end, I should say that we should avoid these statements when you are treating bone and joint infections. The fever is only for 1 day duration. Let me start with antibiotics, and if the child does not respond within a few days, I'll take a surgical reference or a pediatric orthopedic reference. Remember, this is a statement which you should avoid. Remember, it is a medical problem along with a surgical problem. So do not start antibiotics, because we are not going to get a good culture in case antibiotics are started prior. Second is, if you see on ultrasound, there are only a few cc's of pus. Pus thoda hi hai, thoda wo antibiotic se kam ho jayega. That is a wrong statement to do. What you should remember is that whenever there is pus, it should come out. There is a very famous general surgical textbook known as Love and Bailey. This shows that wherever there is pus, it should come out. Pus in the joint always needs to be drained, whether it is 1 cc or 2 cc. That septic arthritis always has to be drained. And the only non-surgical indication in pediatric bone and joint infections is very early osteomyelitis, where there is no abscess formation, which is proven on an MRI, which you can treat with IV antibiotics. Thus, take-home messages. Remember, when you are suspecting osteoarticular infections, do few blood investigations like CBCSR, CRP, and blood culture. Remember to give a shot of IV antibiotics only after you have taken a blood culture. Imaging, primarily X-ray and ultrasound, but most importantly, the MRI, which is the gold standard. If there is any pus formation, surgical drainage is mandatory. Remember, the only non-surgical indication for osteoarticular infections is early osteomyelitis. And finally, antibiotics should be initially IV and then oral, which has to be continued for about 6 weeks. Thank you very much. Do we have any questions for this talk? If not, can I invite the next speaker, Dr. Chasnal Rathod, who will be talking to us on gait anomalies in cerebral palsy.
Hey, hi. Hi, Mandar. Thank you so much. And just a second. So I'll be talking about the gait analysis and its use in treatment. So gait, as we know, is the walking pattern. And normal walking is defined as a highly controlled and coordinated repetitive series of upper limb and lower limb, so that a person can move from one point to other without minimum expenditure of energy. But when we talk of something normal, how do we define something abnormal or which is deviated from the normal? So recently, some time back, there was a silly walk period at Hungarian capital Budapest, where people didn't want to walk normal and they decided to do crazy walking patterns and silly walk patterns. So that's how the world is. And let's get to what is about the gait. So this is Professor Jim Gait, and he's called the father of gait analysis or motion analysis. And he described gait way back in 1983. And he described it as a systematic measurement and description and assessment of quantities which characterize the human locomotion. So the gait analysis has a very wide changing scenario. It was first started in World War II, where it just analyzed the amputees post the World War injured soldiers. And then it was used for equines, that is the horse running, who were popular in the rugby and the derby thing. And later, this from amputees, it came to analyze the adults, and more larger use is currently seen in children with cerebral palsy and other neuromuscular disorders. So for a large time, we were focusing only on neuromuscular disorders. And now the focus is more on sports. And with the AI, now it has been a markerless systems and underwater evaluations and different applications of the gait analysis. So gait analysis can be two types of gait analysis. One is a simple visual gait, like we watch people in the mall or around us or sitting in a cafe. People are just observing people outside about how they are walking. That's an observational gait analysis. And what I'm talking to you about today is a 3D instrumented gait analysis, which is done in a gait lab, also known as motion analysis lab. So this is a simple observational gait. So the child is being made walk in the hospital. We just observe and write down the details, like how the child is walking on toes, what's happening with the knee, is the parent holding the child, is the support needed, and other things. So this is a way of defining an observational gait analysis. It can be done anywhere without a gait lab. It doesn't need special cameras. A mobile phone is sufficient. And then there are certain scoring systems which are to be marked on to evaluate this gait pattern. And then comes a little more modern form where you don't need to sit and mark the walking, different events of gait or the different stages of gait, and the gait lab does for you. So this is a gait lab where I'm attached to. And this gait lab, you will see, is a big hall with multiple, so there's a walkway here, and then there are multiple cameras which are mounted on the wall here. So these cameras are special Nikos M3 cameras. These are very high speed motion cameras. They capture around 200 plus frames in a minute. And these cameras, they pick the reflective markers. So these are the markers which are applied over the child or the patient who has walking problems. So anatomically, there are certain points on the human body as per the skeleton system where these markers are to be placed. And then these markers are picked up by these reflective cameras, which help us to create the motion analysis. Next, if you saw in the gait lab, there was a small square cut out in the floor, which is called the force plate. So this is the force plate. Usually it's covered with the carpet. So force plate is a force plate. So we have here is the AMTI force plates. And these force plates are very sensitive. They record anything which strikes on it. So when a child or a person walks on the force plate, so when there is a strike on the force plate, it creates certain forces. And there is a ground reaction force which is generated and which can be quantified and created into a report, which helps us to understand what's happening, how the forces are, which muscles are weaker, which needs to be worked on with physiotherapy, or do we need to do something to enhance the strength of these muscles. So this is what the force plates does. And this works on the Newton's second law that every action has an equal and opposite reaction. So the moment there is a thump on the force plate, we get the force plate graphs. Second is the gait analysis gives us certain temporospatial parameters apart from the graphs, which are simple like the velocity, the speed with which the person is walking, the cadence, that is the steps per minute. Then how is the foot progression angle? What is the step length, stride length? And a lot of things which are relevant to people when they want to treat someone with a walking problem. And lastly, all this data needs to be processed. So the data processing is a very difficult task, although it's all computerized and very high-tech system, where this child or a person with walking analysis walks nearly 10 to 15 times on the gait hallway. And the whatever data is captured is then analyzed to create or generate a full report which looks like a graph. So this is how usually the Gait lab looks like in a calibration. So in a world of AI where we talk about things, how things would look like in the other world. So this is how the Gait lab looks like after being calibrated. These are the cameras on the wall, and this is where the person is walking. And these are the forces which are generated when stepped onto the force plates. All this gives us a Gait report. And many of people would think that, do we really need this? So in a very wonderful editorial article in one of the famous pediatric ortho journals, it said that it is in a corollary, like taking an expensive car to someone who is knowledgeable about doing a work. And of course, we would not want to take something like an expensive car to a roadside garage. And that's what happens when child with walking problem or a young adult with walking problem goes to the Gait lab. We can cut down on pinpoint what are the problems and accordingly treat them. Other basic simple example would be just like we have an MRI for a back pain. People would always, prior to the advent of MRI, were also treating the back pain with different modalities like X-ray, myelogram, CT, and other things. But with the advent of MRI, things changed. The surgeries became more minimally invasive. Now we can do smaller surgeries, keyhole surgeries. And similarly, the Gait analysis report also helps us to pinpoint the problems and give the best solutions to improve the walking problems in children. So just like how a MRI looks, this is how a Gait report looks when the child has walked down the Gait lab around 10 to 15 times. Whatever you see, the blue lines are what depicts the right side of the lower limb and the upper limb, and the red here depicts the left. So these colors are different for different labs and different systems which are being used. The main thing is that these colors should follow the gray. So the gray represents the normative graph for that particular age and sex of that particular at that particular age of the child whom we are evaluating. Anything which is deviating away from the gray is a problem which needs to be addressed. So what you see here is 3 graphs. This is when you look at the child from the side. This is when you look at them from front. And the last line is when you look at them from the top. So these cameras give a 3D view of the child and create this graph. The horizontal lines, these are the pelvis, this is the hip, this is the knee, this is the ankle and foot overall in the lower zone. So that's how our entire report is generated. Similar thing can be done for the upper extremity, for the entire body. And other than that, there is the kinetics, that is the force graphs are generated. So how does all this extra information help in the treatment? So it helps us to do a pre-op planning. So if you look at these 2 girls, they are almost same age group. They have similar etiology problem. And look at the amount of deformities, they are quite different. The girl on the left side has very obvious equinovarus deformity of the leg, which is very easy to pick up, treat, and diagnose and treat. While the girl on the right, the other side, if you see this one, she has very subtle deformities. Now she has a neurological problem and the parents are concerned about even this subtle walking problem because she's unable to run, participate in school activities, sports activities. And hence the Gait analysis here helps us to pick the subtle problems and make a very good pre-op planning so that the best results can be given. Also, it gives us the dosage of surgery. So without the Gait analysis, somebody would just want to plan a certain degree of planning or decision making, which is like quite generalized to general population. But a Gait analysis helps us to give a very patient-specific dosage of surgery and not a very largely defined surgeries like both lower limbs, this. Like certain places we see in very large camp settings, they just have one column named cerebral palsy surgeries, which are not the right way of treating these children with walking problems because often these problems are asymmetric. Like you look at this child and he would need a very good pre-op planning and managing of the deformities. Third is this has a larger role when the clinical evaluation is not matching with the walking problems. So there are certain correlations we as orthopedic surgeons look into before doing a surgery. And if these correlations do not fix into each other, then probably a gait analysis is a much better tool to decide what surgery might help the child. So it is not a prescription. Doing a gait analysis is not going to let us know what we are supposed to do. It's a combined work, and it is one of the things, apart from the physical examination, the radiological examination, it is just one part of the triangle which needs to be done so that we get more fine-tuning of the treatment outcome. So if you look at this child, he is a child with a crouch gait. He's around 14 years old. And this is how the post 4 years follow-up looks like. So gait analysis enables us to understand the problem and make the problem so much better in terms of strengthening and treating the deformity. So this child has just undergone a femur osteotomy and a patellar tendon advancement and a good 4 years of physiotherapy on all the weak muscles which were visible on the gait analysis. And this is how we get a very good result. This child aims to be a physiotherapist in future, and I'm really happy to see that from this gait to that, he's now a very happy, normal child walking around with his peers, going to the mall and doing all the activities. So post-operatively, if we look at now these two gaits, it is just a feeling that yes, the child is walking better, but not always the kids would walk these better. And post-operatively, we need to quantify the gait. Many a times we would say that yes, post-surgery, the child is walking better, the child is walking good, or the child is walking differently. And that's why the gait analysis gives us certain scoring system, and the 3D gait labs gives us a score which is called the gait profile score. So it's a single digit number which quantifies the walking of the child, which will help us to evaluate what was the score pre-surgery and now what is the score post-surgery. So this is one more example of a very much more severe severe deformities in a child with cerebral palsy. He's around 12 years old. He had previously undergone surgeries without a use of gait analysis. And I have seen his certain videos, and I think usage of gait lab would have made a much better outcome at this age for him. However, with the proper planning and surgeries, currently he is into this state. The child had been completely off school post the first surgery he underwent for nearly 4 to 5 years. He was just sitting in the house, and he at least needed 2 people to pick him up and even take him to the washroom around. Now he's very much independent. He walks around with a simple support, and certainly the surgery has helped to change the way he would walk. So every time looking at such children or doing a gait analysis doesn't mean that they would always need a surgery. Gait analysis is a very good tool, and it helps us to realize that not all children need surgery. And this is a very good example where just wearing of splint has made a drastic change and in the gait pattern, and it has improved the way the child's body was going posteriorly and the center of body mass was falling behind, and just wearing of splint has improved him to walk much more better. Somebody without a gait report or a gait analysis would probably want to operate this child and make them more worse or a non-walker. And that's how the gait makes a difference in deciding whether a surgery is actually needed or not. There are endless literatures in the literature available which talk about how the gait analysis leads to reduction in surgeries, leads to additional procedures needed, or leads to certain change of decision making. And also it shows certain improvement which are already being explained in the literature. And despite of so much of use and a good use and good outcomes, there is a very nice recent paper, which is from Sickets, Toronto, where the author says that there is still a lot of reluctance among the orthopedic surgeons to use this tool. Mainly one, because it's complex, it's time consuming, it has a long learning curve, it's expensive. And although nobody is focusing that it helps in making it a better decision making and give correct interventions, what he also emphasizes is probably those who are already using it need to come up with more better clinical trials and evidence so that people get more aware of using this. So primarily there needs to be an awareness rather than a reluctance to use this amazing tool. And over the years, it has changed the way children were operated. So we used to call birthday syndrome. That is, every year a child of CP would be in the hospital because every year they would be getting some surgery done. So in the last 10-15 years, the birthday surgery syndrome changed to single event multi-level surgery, where they would probably get operated at certain age groups. And now with the advent of kinetics and kinematics and all the gait analysis, there is a more finer way of deciding the dosage of surgery. And no longer we call the surgeries in CP this terms, but we use the term dosage of surgery. And it has changed the way the surgeries are performed. So there are certain still places in our country where in the camp settings, these surgeries are still be done for children who don't even need these surgeries. And with the advent of gait analysis, we are now focusing more on better probably limb specific and individual specific surgeries. So there has been a lot of change with a very good, even this article mentions that it has changed the way the inappropriate surgical decision makings were done and how there has been decreases in the surgeries which are being very rampantly done, which don't add much of quality of life in children, but they can make them more worse. So apart from just doing the gait, additionally, the gait analysis, what is done is gives us the electromyography while walking or in static evaluations. And this can be used in children who need tendon transfers or lengthening. So this is a child with weaker tibialis anterior tendon post the lengthening. And had they undergone a gait analysis before, probably something would have been done for this muscle while doing the lengthening behind. And she would have walked much better if this tendon was shortened, advanced, or an additional procedure was added. So now currently it's weak. The parents have already undergone one surgery and now going for a second surgery is going to be tough. So they're going to spend a lot of time in rehab and physio trying to strengthen the tendon, which is now weaker. And this is an additional information which the Gait Lab also provides. So the Gait Lab, yes, it's a great tool pre-operatively. It helps to pick not only subtle problems, but yes, the complex problems as well, and helps us to get a very good dosage of surgery after correlating it with clinical exam and a radiological findings. Post-operatively, it helps us to quantify our outcome. The scoring system is now used as a research tool and a very good tool for documentation of the gait changes in children with CP. And just like any other technology, this also has certain limitations. And there could be errors, human errors, software errors. Just like our mobile phones, the lab also needs an upgrade in terms of software and hardware. A good team is needed to do this entire evaluation and analysis. It can't be performed in children who are non-walkers or children who are less than 3 years of age or less than 100 centimeters in height. And there could be an interreliability amongst different labs or the users. So, is it must? So, yes, it could be for people who are certainly treating cerebral palsy because they know the advantages of it. It gives us a supplementary data in additional to the clinical and the radiological data we have in hand. And when the clinical findings don't match, yes, it's a must to do that. When there are combination of gait patterns, these are specifically for the orthopedic surgeons who know that how the stiff knee can be difficult to treat. And in combinations of gait patterns, yes, this gait analysis helps us a lot. It is must when the pelvic tilts are not self-explanatory or cannot be explained with the help of static evaluations. And in such cases, the gait analysis helps. Currently in India, we have one of the largest labs in Asia for sports. And apart from that, in Mumbai, there are certain gait labs which helps to evaluate the kids or people with problems. It has a wide use in terms of orthotics or in amputees, outdoors like in sports, golfers, and in runners. So running analysis is available in certain labs as well here. And there are extended applications like clinical sports, and even in the research and third-party integrations. So what is the future of this gait lab? So they might not be confined to the room like I showed you in the beginning, like we have a lab which is there in the hallway. And the future would be having these labs more in the outside settings where people are performing their activities or sports or walking around in day-to-day places. That would be the thing which is the more of future of gait analysis labs. And anyone who feels that any child who has problems with walking analysis and they need to be evaluated or treated, we are always happy to have them at SRCC Children's, and I could help them to get a gait analysis and further evaluation and treatment accordingly. So if there are any questions related to the gait, I'm happy to take them here. It's a very complex evaluation and test, and even learning the gait, as I mentioned, is a little complex. It takes time, but yeah, the results are phenomenal, and it just certainly helps the children with walking problems. Thank you. So if we have any questions, we can take that, or next, I would request Dr. Jaideep to share the screen and start with his talk.
Thank you, Chasnal, for a nice lecture. Good afternoon, everybody. I'm just presenting the update. Can you hear? Chasnal, my voice is clear?
Yeah, it's visible. You need to share your slides.
Myself, Dr. Jaideep, I'm just updating about the pediatric trauma and fracture. So everyone can see day-to-day activity. So it is the most common fracture of the pediatrics or common site are humerus, radius ulna, tibia and fibula. Most common time for the fracture in pediatric is generally in the evening, 4 to 6. And most common season when the vacation start or weekend. So fracture is common in boys compared to girls. 50% boys and 20% of the girl are expected to have fracture during the
Jaideep, your slides, I can't see them, so you need to do full screen. No, what I'm seeing is just a white screen with the folder.
1 minute.
Yeah, now it's visible.
So 50% of boys and 20% of girls are expected to have fracture during the childhood. Up to 20% children sustain injury every year. 10% of this consistent with the fracture. 2% will require some intervention. And 20% pediatric fracture are involved in the growth plate. Practical statistics, 30% of trauma practice will be pediatric fracture. 80% will be treated by conservatively. So learn the art of pediatric fracture. So I am showing the some cases who require the intervention. Most of the cases will just treated conservatively. Here you can see the 8-year male child who got the sustained injury in fall. You can see the clinically there is a deformity. This is the X-ray. Here is a volar angulation deformity. Clinically you can also notice. So these are the clinical picture. We have taken the child under the anesthesia and we corrected the deformity and reduced the fracture. You can see here, this is the position. Different fracture has a different technique to reduce and give the plaster immobilization. So here you can see nicely reduced fracture is maintaining the interosseous space. This is a post-op X-ray. This is another case. History of fall from the trampoline with severe injury, and that this deformity is opposite to previous. You can see significant deformity here. The forearm is completely bowed. So first thought is required surgery or nail something. So we have to assess what are the fracture pattern, what are the injury. We always try to reduce close first. So here you can see under the anesthesia, because in pediatric all child require the anesthesia because pain. So we'll reduce this fracture under the sedation, corrected the deformity, applying the 3-point fixation. Now see, gradually we corrected the deformity. So this is the post-op X-ray and fracture is nicely healed at 4 weeks. Another case, 10-year child, 16 days old injury. Here is a distal radius facial injury, Salter and is type 2. X-ray after the plaster removal. Generally, all of the facial injury we reduce less than 5 days. Otherwise, there are chances of the growth arrest. We waited for remodeling. This is 3-month post injury. You can see nicely this fracture without any intervention is healing well. This is 6-month full range of movement, not require any surgery. So 1 year post trauma, full healing of the fracture and full range of movement. He got clinical full range. You can see here. Another case, I'm just going upper limb injury and lower limb injury, different areas of fracture which are the most common in children. He got fracture both distal radius and ulna. You can see here gross deformity, gross displacement, almost polar angulation. We reduce close, we apply the J's because these fracture are difficult to reduce and maintain the post-operative alignment. So we use our Indian J's Joshi external stabilizer fixator. We just apply the 1 pin proximal, 1 pin distally, distracted the fracture and just align. You can see here, it is nicely healed. He got full range of movement at 10 months follow-up. This is the most common fracture, supracondylar humerus fracture. We always get one fracture every week. This is require emergency. So fall on the outside, severely type 3 supracondylar fracture with displace. Distal pulsation are present. It require emergency. This fracture need attention. Not required to do in emergency night. We have to see vital. If there is a neurovascular injury, distal pulsation option, then we do immediately. This we did the close reduction and fix with the cross pin. The fracture is nicely healed at 4 weeks. This is a 7-year female child. She just got the stuck of her index finger in the door. These are the most common injury we see in emergency rooms. So she got nail bed injury with fracture of the distal phalanx. We suture that, we reposition the nail bed and fix the fracture with the K wire. You can see at 3 weeks the fracture is healed completely. The wound is nail bed is good, and we remove the wire here. So there are so many upper limb fracture, but due to the time limit, we are showing some frequent. Those are the most common. Now we move to lower limb fracture. This is the most common fracture, femur fracture. History of fall from the height. He just got a fracture left femur. We reduce close. We put the titanium elastic nail on the post-op X-ray. You can see the fracture is nicely reduced. There is no gap at fracture site. This is at 1 year follow. We remove the implant at 1 year. There is no lip length discrepancy here. The fracture is nicely healed and he is clinically full range of movement here. This is the child. He just playing in the park. The leg is stuck up in the dumbbell drum. So he got tibia fracture at the mid shaft. Luckily, that force is less. Otherwise, he will get some soft tissue involvement. You can see here left tibia fracture with fibula. So much displacement. Clinically, the leg is completely deviated. So same day we had taken the anesthesia, we reduced closely and just apply the plaster, not done any implantation or tense nail. So 6 weeks is completely heel fracture with good alignment and started doing all the activity. You can see this. So these are the another case, fracture distal tibia with physeal injury. This will require some time to CT scan. On X-ray, we can just confuse sometime it is a physeal injury, it extending to the joint or not. So we did the CT scan. You can see the fracture line is extending to joint line. So this requires proper alignment. This is a 3D CT scan. You can see the fracture line extending into the joint. So we reduce close. We temporarily fix with the guide wire, finally fix with the titanium elastic screw. These are the intraoperative picture. This is the 3 months follow, nicely healing of the fracture with maintaining the joint line. This is another case, older child with a different fracture. You can see here, this is a triplane we fix with the two screw, and 2 months she is able to walk and do all the activity. This is a 9 month post-op. This is a difficult fracture compared on the same physeal injury. Did the CT scan, you can see here the physis is fracture, epiphysis is fracture and metaphysis. You can see here clearly there is a Mercedes-Benz sign. All you can see. Some of the cases of the ankle fracture will require to do the CT scan to know the geometry of the fracture, to plan our fracture, what modality of the fracture treatment is required. So with the CT, we know what is the fracture configuratory. We closely reduce, we fix with the guide wire, we did the intraoperative orthogram, see the alignment and fix with the screws. So after fixing, you can see nicely reduce the fracture. Joint line is maintained. This is a post-op X-ray. This is a 4 week and it is 4 years follow. No growth arrest. She is doing full range of movement. There is another 13-year child with a middle malleolus fracture. So we reduce same. She presented almost a week later. Previously, somebody is treated with a conservative plaster. We fixed this fracture and she started immediately mobilization after 3 weeks with air cast. Thank you. So I'm just shortly cover all the fractures. Difficult to cover all the fracture in this lecture. So anybody has any question, they can ask me because so many fractures. Those are the frequently seen in the casualty. That's why I've shown here. Hello.
Jaideep.
Yeah. Anyone has any question?
I think they'll type if they have in the chat box because
Yeah,
everyone is mute. And so hope it was a great masterclass for all of you. We did try to cover certain updates and recent techniques and advances in the treatment in pediatric orthopedics. And if there are any more queries, we are always there to reach out and help. And even if any kids need any referral for any sort of orthopedic treatment, one of us is always there at SRCC Children's Hospital. And thank you so much for joining us. Thanks a lot.
Thank you very much.
Yeah. So we can end the meeting, the admin, and thank you.